And thank you again for reminding me. I appreciate it. I remember and I forget. It's what they call old age, right? All right. Chapters 43, Hematology and Immunology. So hematology and immunology, immunologic dysfunction, is how do you figure out something's going on? Well, number one, it's the history, always number one. What will the child see? Many hematological conditions are anemias. And anemias is what we see is we have a low hemoglobin, a low hematocrit, and if we don't have enough hemoglobin, there's not all those red blood cells to carry oxygen and iron around to the body, right? So that body becomes fatigued. It can't, a lot of activity, decreased energy. They're resting more, which is very unnormal. I mean, the color you might see, the paleness, but most of all, the first thing parents notice is that lack of energy. So that would be that history that we would see. Another thing we would see with anemias might be a really loud murmur in there. When you don't have a big hemoglobin hematocrit in there, you don't have a lot of cells. And those cells tend to be bouncing off each other and it swishes. And you might hear that swishing, which sounds like a murmur when you listen to the heart. And of course, your heart rates are going to be more elevated because, again, the body's trying to get the oxygen and food around, and it just really can't. So doing that complete blood count is going to confirm that what we're seeing is going to be something to do with a hematological problem. As I said, many a times it has to do with that low hemoglobin hematocrit and anemias. As children get older, we know that they're going to have, they're not going to eat the way they should. They're not going to eat the foods, the green leafy vegetables, the eggs, the proteins that they need, and they get a poor diet because of that. When we see children having frequent infections, something's going on, and it could be an immunological dysfunction that we didn't know about at birth, or even, it's just something that they got as they go along. So doing that, looking at that white blood cells, looking at the type of white blood cells, looking at that red blood cells and hemoglobin, it's all going to put a picture together. So that complete blood count, or CBC, so important. And then we'd have other conditions which causes bleeding. I mean, the one big thing you think of bleeding, you think of hemophilia, but there are many more. So as I said, the most common of all hematological disorders in children is anemia. And what it is there's a decreased number of red blood cells or hemoglobin. When you don't have enough of those red blood cells or hemoglobin, what do the red blood cells do? Well, they carry oxygen around to the body and iron, right? And if you don't feed the body what it wants, the oxygen, which gives it the gas, the energy to move, to be able to move around without getting short of breath and tired, because you have all the oxygens there, because you have a good number of red blood cells. When you don't, that's when you're going to see the child is going to be resting and more fatigued more easily. So you don't have enough cells, you don't have enough oxygen, you don't have enough hemoglobin. This is what happens. Sometimes we have conditions that causes depletion of red blood cells or hemoglobin. We'll talk about those. And then sometimes we have the changing in cells. When we think the change of a cell, you think sickle cell, right? And yes, we will be talking about that. In children, we define a anemia less than 10. And we think that's a really appropriate number for children. So let's go into some of those types of anemias. I'm going to try to make them understandable. We'll go over them a little bit more. We have a decreased red blood cell production. That can happen. We have an increased red blood cell loss, means they are, being destroyed quicker and they're going away quicker. Or then we have an increase in red blood cell destruction. So we can have them lost due to blood being expelled from the body in one way. And the other one, the cells they die, they burst, and they don't live long lives. So the decreased red blood cell production, we're going to see that usually in nutritional deficiencies. The big one we think of is iron deficient anemia. You don't have enough iron, you're not going to make red blood cells, and you're not going to have oxygen to carry around, and you're going to see, again, that fatigue in those children. We also see it in things like B12 deficiency. And B12 deficiencies has to do with that intrinsic factor of the stomach, right? And if we don't have it, we're going to get B12 injections, right? And again, we do have some chronic blood loss, could be things, but let's not focus on that there because that can go over to the blood loss. We also have something called bone marrow failure. Well, where are red blood cells formed? They're formed in bone marrow, right? So there's one thing that we say the type of anemia is called aplastic anemia. We're going to go in it more, but you have literally don't have enough red blood cells produced, and you don't have blood cells, you don't have platelets, you don't have white blood cells produced. And this is something where you're going to have to get transfusions to be able to be alive, or you need some bone marrow transplant, which we're going to go into. Also, of course, we have those leukemias, like acute lymphocytic leukemia, neuroblastomas. Any of that do deplete your red blood cells. Then we're going to go into the bleeding stuff. The nosebleeds actually tell many doctors that there's an underlying condition where they didn't show it up before. I've had many a child come in that they keep getting these nosebleeds, and they say, all right, yeah, the doctor says it was just due to this upper respiratory. We painted it with Vaseline or whatever they want because there's little capillaries there, but this is now the fourth nosebleed in a month. Something's wrong. Well, they're going to rule out bleeding coagulopathies. Now, what are blood works that we would do in a bleeding coagulopathy problem? Well, CBC is always number one. We're going to show there's a depletion, but how about if we do that prothrombin time, or that acute partial thromboplastin time? So PTTs, PTs, and then there's thrombin and all different other stuff. But PT, PTT are your big ones, and then looking at your CBC. And some of those names are ITP and DIC, and we're going to go into what those are. Just remember, in the word ITP, it's acute idiopathic thrombocytopenia purpura. Now say that 3 times quick. But the P means platelets, so decreased platelets, okay? P equals platelets, and that one is specific to ITP. Then we have the cells that burst quickly, they're gone, and that is with your sickle cell. Sickle cell's a big one. Those cells are born and they're crooked and they're like little C's, like sickles. We're going to go into the treatment and all that, but those cells die quickly. And then another one is called thalassemia. This is usually from the Mediterranean, and these cells, they're square shaped, rectangular shaped, and they're burst quickly. So we're going to go into that. And then, of course, we have those immunological things that happen. It could be due to drugs, toxic substances, etc. So as I said, consequence of anemia, what do you hear? You've got that hemodilution. So you've got the packed cells in that one slide, and then you have them very sparse in the other, which is anemic. And it swishes and it bangs off the side of the cell walls. And that's when you hear that turbulence going on in the chest. Again, you can have that elevated heart rate, trying to get the little bit of oxygen around is what you see. And remember, if we don't treat anemia, the heart's going to be overworked and you could go into failure. So getting those hemoglobin hematocrits up are very important. Remember, if the cells don't get enough oxygen, you know, they're iron, they don't get their food, there's not going to be a lot of growth, and you're going to see that cyanosis and growth retardation. So how are we going to diagnose these anemias? As I said, history, physical, and a CBC. Another thing we need to look at with anemia is don't always assume it's a nutritional thing when we see normal cells and there's nothing else to blame it on. They always will do a stool for occult blood, or even looking for maybe endoscopy, looking, is there a bleeding ulcer? Something happening somewhere that we are not thinking about. So looking for that underlying cause. Now, it doesn't matter why the hemoglobin hematocrit is low. We can't let that child continue to go on without replacing it. So we do give transfusions. It will build up the blood cells. But remember, if it is a nutrition, um, we're going to just increase nutrition. If it's due to hemorrhages anywhere, blood bleeding, we know we're going to give it that way. But as long as that blood count isn't too low, we're just going to change the nutrition when we're giving for iron deficient anemias. What do we do in the meantime? Well, these kids, they don't have enough oxygen. They're going to be tired. We're going to be giving IV fluids just for the volume in the vessels so that we're making the blood flow a little bit easier. And they say oxygen, but it is extremely controversial. I mean, yes, it can help a little bit, but if you don't have cells to carry oxygen, is it really going to work? So that's that quandary. Is it work? Does it not? But we are going to have them rest. We're not going to tax them. They shouldn't be up running around playing sports until we correct it, get that hemoglobin back up. They should be more on bed rest and limited activities. One of the things we do when we assess these children is number one, age, looking at it. I mean, a toddler could have more chance of nutritional anemia, right? They're picky eaters. Older kids, adolescents could have it. Same thing. They're not eating, right? Can't get a power bar and a bottle of water and run for the day. Even though they should be getting nutrition and know better, those are the two age groups I'd be looking at. Ethnic or racial background. Well, we know sickle cell, right? African American, right? African culture, 25% of your population. If both parents are with the trait, you're going to have, the sickle cell. So that's a big thing. Another one is, I mentioned it briefly, thalassemia is from the Mediterranean Sea. So it's somewhere in the Middle East, somewhere over there where they do have what we call thalassemia. We're going to do that history, find out what's going on. And as I said, stool for occult blood is important because that rules out active bleeding. Now, when you're talking about anemia, there are things we need to do. And one of them is blood tests. So getting the child prepared for that because they are going to get a pinch. They are going to have a stick. So make sure that they are aware what you're going to do. And again, we do everything as atraumatic as possible, using numbing creams, whatever we have to decrease the amount of pain in any procedure we do on a child. I think they hate being held down most of all, even beyond the pain, to tell you the truth. But again, having parents there helps. Of course, we're going to do things that decrease the oxygen needs. Like I said, not going to be running around crazy until we get those hemoglobins up. And of course, those prevention of those complications and heart failure, et cetera, because we're not treating it. So iron deficient anemia is caused by an inadequate supply of iron. It is usually preventable. Today, unlike years ago, we didn't give iron fortified formula, believe it or not, back when I was with my children, and they're 30 something now. But today we know that starting it early can only prevent it. And if you don't need it, your body expels it. So it doesn't harm the child in any way. It can only help. So iron fortified cereals is what we introduce at 6 months. And formulas that we give those children who are not breastfed, we give iron fortified because we want to make sure their iron is there. There's all sorts of special formulas for premature infants. It has extra stuff in it, extra calories, so they have to drink less to get the same calories, et cetera, et cetera. So there's always differences in the premature. I already told you about adolescents. They got that big growth, what they call the pre-adolescent growth spurt. Remember that 25%? So, and they're not eating. So that again can cause it. There are other things that can occur. Now, some parents, some can't afford formula, but they think that they can just give whole milk to an infant. And that's what the milk baby is when only whole milk is given. It doesn't have those extra vitamins and minerals and iron in it that they need. So we don't have many of them anymore. There's so many programs out for all children. You know, I think of WIC, which is a government a thing where that you can say that you need formula, you need whatever for your babies, and they do supply it. So how do we treat iron deficient anemia? Well, number one, it's nutritional. And if nutrition doesn't work, then we're going to do some sort of iron supplementation. One of the iron supplementations is liquid in the younger kids. Remember to try to get it in the back of the throat because it can take their teeth and cause them to turn brown, right? As they're older, sip it through a straw so we get it to the back. And one of the things we forget, because we will with older people, but not the kids, remember orange juice helps it because iron must be broken down in the stomach for it to work. So you have gastric acid and then orange juice has acid and it breaks it down more. Doesn't matter adult or children. You know, if you have a kid who's 1 year old, they can have orange juice. So why not give them a little orange juice when they're taking their iron, and it will help make sure it gets in there. So sickle cell anemia, this is those sickle cells. As I said, if both of the parents have a trait, it's going to be 25% of chance of having the disease. As I said, it's African Americans that will, or Native Americans, there are the carriers. If you have a trait, you don't have a disease. You only can pass it on to your child. Now, this is something that many students have a trouble with understanding. So let me try to explain it to understand what happens. So you have these sickle-shaped cells, and you've all these vessels that bifurcate in the body and get smaller and smaller. What happens is the sickle cell comes to a bifurcation, and it sort of gets caught up there, and it blocks it, so it can't go down into that vessel. And then, of course, what happens with other blood, it backs up behind it and it swells because it keeps backing up, right? And it can't get through, causing that pain and that swelling and destruction of tissue. And then beyond that is not getting nutrition either. So what would we need to do, number one, to get that sickle cell from getting away and getting down that vessel? Now, the child is in pain. It is a priority, but your first priority, let's give some fluid, dilate those veins. So number one thing, you have a child in a sickle cell crisis. Usually, I mean, there's many different places it could be. Could be elbows, could be chest, could be knees, could be abdomen. And you can see them anywhere. You can see them sickled in their head, in their eyes. Those are very uncommon. Usually it's more of an extremity and some in the chest. We see it quite a bit too. But the first thing we do is start an IV and give a bolus of normal saline. What does that do? Dilates the vessel. And what else can we do? Let's put some heat on the area. What does heat do? Vasodilatation. So now we've started to remove that backed up of all these sickle cells that are swelling, causing the pain. Now, it doesn't mean in my other hand, I don't have morphine, a pain medicine. I will have it in the other hand, but you could keep giving morphine, and unless you treat and get rid of that sickle clog per se, it's not, you're going to keep giving pain medicine. It's not going to work. So number one, and you have test exams, HESIs, and NCLEX. Number one, fluid, dilate it, put some heat on it, get it moving around, and then we're going to give those medicines there. So what happens? How do we get these sickle crisis? Well, number one is always stress. Stress is always, you know, with many of these autoimmune type stuff, stress is a big thing. But anything that increases the body need for oxygen. Now, trauma, bruising, infection, fever, that burns up a lot of fluid. So now you're getting dehydrated. How about that child who plays sports? They need to have a bottle of water or electrolyte drink in their hand. as they're playing sports, keep hydrated. Or what happens? They sweat, 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 sweat. They lose their volume. They're going to have a sickle crisis. So these children must be taught the importance of maintaining hydration. I mean, can you imagine being in Florida and it's 94 degrees outside and they're playing soccer or baseball and they're not hydrating? Can you imagine? In one afternoon, they can go into a sickle crisis. So keep the fluid going, keep it going, because if you don't, it's going to clog up. You're going to cause that pain, the swelling, and below it, you're going to see that hypoxia because there's no cells getting there, and if cell death will occur. So as I said, number one, you have a kid with sickle cell. Number one, you want them to relax, get the IV in and hydrate them right away. You're going to put the heat on there. And of course, you're going to be giving them something for pain. And, children, it took a long time for professional care professionals to realize children are, even newborns, have pain, and we need to treat it and treat it properly. So making sure that they get their proper dosages, because children aren't going to ask because they're always afraid of a pinch, or they're afraid that they're not going to like the taste of it. So we're just going to say, if you're in pain, I'll just put it through the tube here. You don't feel it. But it will help you. And then they can get up and sit in the chair or walk, go to the playroom, whatever they want to do. Now, another thing that happens is there's electrolyte issues. We're going to have to keep that replaced, your potassiums. And many times, sickle cells tend to die very, very quickly. It is not uncommon for a child to come in a sickle cell crisis and their hemoglobin hematocrit is 6 and 18, 7 and 21. That's a good one. So as an ER nurse, you get a sickle cell child in, you're starting an IV, putting heat, giving something for pain, making sure that we're monitoring those electrolytes. And many of the times they're coming in because of low-grade fevers too. Something antibiotics for the infection there. But these children, one of the things is to make sure that they're medicated for pain completely and have them rest. Now, you will be prepared. These children will get blood, usually in the emergency room before they even go upstairs. So it is a child that requires a lot of attention and takes up a lot of time. So you have to be really organized in order to get everything done for these kids. But again, you're giving blood and it's good blood, goes in and it helps them initially. They feel more chipper, but again, remember that blood's going to die off. So we need to watch it. Now, how do we watch those things? Well, we're going to be monitoring retic counts, seeing how that bone marrow is working and how cells are doing. And again, blood transfusions help. Because remember, we put oxygen on, it really doesn't work. There's not cells there to carry around, especially, I'm telling you, their hemoglobins are very low. I think the highest one I've seen is 7. I've seen them down to 4. So it is quite low when they come in. So blood transfusions do give oxygen back, and that's the way to do it for these children. Prognosis is there is no cure. Is something that they're going to have to be there and understand and make sure that they're ahead of it at all times. They have infections. Any child, any adult with an immunocompromised, any diagnosis, they have a low-grade fever, they need treatment, call their doctor, and they need to be placed on antibiotics. Sickle cells are the same way. They do need, as soon as they have that fever, to call the doctor and call in a prescription or get to urgent care ER in order to get that IV antibiotic. These children can live longer than ever today. 5th, 6th decade. It's getting better because we're understanding it more. We know when they needed treatment. So the prognosis is better. So educate. How are you going to educate these parents? Well, as I've been saying, early intervention. You have a fever, come in. They start a sickle attack, come in. They're also given penicillin, 1 pill a day, prophylactic, and this can help prevent infections. It doesn't always. Another thing that we don't think about is those sickle cells in the brain. This could be a mini stroke going on. So if we see a child with a headache with sickle cell, always think sickle in the head, which could be a mini stroke going on. So checking neuroscience, very important, okay? And it could be in the chest, and it could mimic something like a blood clot, a pulmonary embolus. So these things we need to look at. Now, these kids, they can lead a normal life as long as they're taking their medicines, that if they have symptoms, get treated quickly, and keeping themselves hydrated. I mean, it's always having that fluid with them, and drinking as much as they can and keeping that blood flowing, okay? Because if it slows down, you're going to go to sickle. Now, thalassemia is very similar to sickle because they have a weird shaped cells. I call them the rectangular or square shaped cells. And this is from the Mediterranean Sea, these people here. And these cells burst. They burst, okay? What is inside cells? Your oxygen and iron, right? So what does that cause? It causes a low hemoglobin hematocrit. Now, there's all types of thalassemia. I don't ask you to remember all of them. Most of all, when we think of thalassemia, we think of Cooley's anemia, which is the most severe of all of them. And usually when you've got questions of thalassemia, it's all about the major. This is those cells are bursting, bursting, bursting. They don't live long. And these children who can become adults need transfusions to live. How frequent depends on how quickly those cells are being burst. Now, we don't necessarily see these things like sickle cell. We might see something at birth. We'll see those sickle cells and we'll know that it's sickle cell. Thalassemia, we may not. Because initially you have mom's hemoglobin hematocrit, and that looks like good blood. Well, then what happens? Mom's cells die off, and then the body of the baby starts making its own cells. And what happens? Well, it's about 6 weeks of age. You're going to start to see those cells changing, and you're going to start seeing they're bursting, and now you're going to see anemia. But the thing you're going to see, which is going to set off the mind of the physician, the child's not going to grow. You don't have oxygen, you don't have iron. What happens? Nutrition to the cells. They're not going to grow. And you're going to see those things. So what will they do to diagnosis? Well, they can do a simple CBC. They can look at the cells and they'll know that the shape of the cells are wrong. And then they'll know what they need to do in order to help these children. Now, some of the things, as I said, for like the Cooley's anemia, which is basically what we think of when we think of thalassemia, is that we need blood transfusions to live because you need to keep the hemoglobin levels up. And your body is not producing cells that are going to work. They're dying very quickly. But what happens? That bursting of cells. I've said losing oxygen and losing iron. What happens? Your body becomes oversaturated with iron. Now you're iron toxic. It's just like taking too much iron. It's something that can really harm the body. So we must do things on these children, monitor iron levels, and making sure they're getting medicines to stop that iron from staying in the body, to get rid of it. Now, we have stuff by mouth that we can take called Desferal or defoxamine, which it binds to the iron and you excrete it out through the urine. Or we can do something called apheresis. Now, apheresis is like a dialysis, but it doesn't produce urine. It just takes whatever component off the blood and gets rid of it. It's pretty neat. It's actually, we do quite a bit of it in the pediatric ICU, where we need to get certain cells off that are creating problems with the child, and another nurse runs it while the other nurse takes care of the child. So it can be done. So how do we manage thalassemia? Well, they have to have their transfusions. That's the cure. It's not a cure, it's maintaining life. So these children will always be coming in, always need to sit down, always get their transfusions, whether it's once a week, once a month, it depends on the child. There's no set date or time, okay? And then they're also going to have to be monitoring that iron and making sure that either they take the PO, chelation therapy, or that apheresis machine. Again, another time to go in for treatment to get that iron pulled off the body. These children are in and out, constantly getting pinched with IVs. Usually they have ports that they put in so that, we numb them, put it in, but it is a lot of anxiety. And these poor children and families are dealing with a chronic condition which requires intensive care. So one thing that can happen, yes, we can give blood transfusion, but many a times children, can you imagine if they had a very rare blood type and they need blood transfusions all the time? Or what if during a blood transfusion, they get a really weird antigen in there and now it's really hard to cross match their blood? That could be a problem. And then, of course, you're always watching out for blood transfusion reactions. As I said, these children can live into adults. Same sort of thing as long as they're doing what they have to do. What happens is, so if you think about the blood, so we give an infusion, a blood transfusion, and your hemoglobin goes up. And then those cells die off pretty quickly. So you're going high hemoglobin, low hemoglobin, high hemoglobin, another blood transfusion. And then again, so your heart is having to work in between there, pumping, getting oxygen around. Heart disease, heart failure is huge because the heart is being overworked. Many times, because we don't want their own body to produce cells because they're non-functional, they don't work, they take the spleen out, and that can help. But again, they're immunosuppressed, and many of them get sepsis postoperatively, and which can cause multi-organ failure too. They're saying maybe a bone marrow transplantation is a potential cure, but again, they don't know for sure, really. There's still a lot of investigation going on. Now, aplastic anemia. So pancocytopenia is all forms of the blood are depressed. That means you have anemia, hemoglobin, hematocrit are low, leukopenia, no white blood cells, thrombocytopenia, P, platelets are low. So you're going to be bleeding, you have no white count, and your hemoglobin's low. That is, the severe form of your aplastic anemia. It's usually what we think of, again, as we're talking about anemia and exams and tests, and, most of what we see. Hypoplastic anemia is the RBCs are low, but there are normal WBCs and platelets. But when we think of aplastic, it's the anemia, low hemoglobin hematocrit, leukopenia, low white cells, and then, of course, thrombocytopenia, which is low platelets. What we do to treat this is put them on some immunosuppressive therapy, trying to, calm their bodies down. We try bone marrow transplant, and we treat them just like we do with leukemia with chemotherapy agents to try to switch their body around. Now we're going to talk about those bleeding, clotting sort of things. And we think of it, the first thing is always bleeding a lot. You think of hemophilia. Hemophilia is an X-linked recessive trait. Mommy gives it. And we don't always know it right at birth. Sometimes we find it later when we see bleeding going on. There are 3 different types of hemophilia that we've identified. There's the one that you think of, which is factor 8. That's most of them. We do have some called Christmas disease, but it's a deficiency of factor 9. Remember, all these factors help in clotting blood so you don't keep bleeding, okay? And then there's something called von Willebrand's factor, but it's usually von Willebrand, which is like could be factor 10, but this research guy named von Willebrand found it, so he put his name on it. And then there's factor 8. Those together, again, they are little components that help the blood clot. They're not there. So many times you will not know that a child has a bleeding coagulopathy. So what do we do to diagnose these children? What would be some signs? Well, you would see bleeding and bleeding and bleeding. Get a big cut and it's bleeding and it doesn't stop. But what about that bruise inside the leg, the knee, the arm, the elbow, right? Kids fall down. That's going to swell up and call what we call a arthrosis. The joint sac's going to be full of blood and keeps bleeding. And then, of course, ecchymosis, that just keeps getting bigger and bigger. So I said it's X-linked. So what do we see in hemophilia? Well, you're going to see now getting factors back take a week. So you're not going to have that information right away. Is it factor 8, factor 9? You're not going to see that. So what are those simple lab tests that you'll see? Well, that prolonged partial thromboplastin time, a PTT, it's going to be prolonged. It should be what, below 40 in most labs? It's over 100, 200. It's going to be prolonged, which means the blood is thin as thin as thin. It's just going to bleed, bleed, bleed. But if you look at it, the platelet count is normal. So you see the PTT elevated, you're going to see the platelets normal, and you're going to say, okay, this is probably your hemophilia. There's other things that we monitor for bleeding, the parathyroid hormone, the parathormone, and the fibrinogen levels are also part of the cascade of bleeding and clotting factors. But as I said, if the PTT is elevated and you're going to see a platelet count normal. So how do we treat hemophilia? Well, what's pretty neat about hemophilia is we're teaching parents and children how to take care of it at home. And I have a story about this little 9-year-old kid. He was a little bit younger, a little boy, 7 to 9, somewhere around there, came in with his dad, and he had fallen down on his knee, and his knee was swollen. And he tried to get a hold of his doctor, and they couldn't get a hold of him to say, should I give this dose? Apparently, he had one recently of the factor. So he wanted, somebody to tell him yes or no. So our doc said, yes, go ahead, give it. And they had brought it with them. Well, I had a brand new nurse orienting and a brand new nurse to nursing. And I was orienting her. And the dad said, do you mind if I give the factor to him? I said, no, it's your child. You brought the factor. I said, can we watch? And I did. This father and this son, the son chose the vein in his arm that he was going to use. He used just one of those little butterflies that we would take blood with. That was part of the equipment. It wasn't an IV, just a little butterfly. And this child held the arm. The father washed his hands, prepared the whole thing, had his gloves on, and he wiped it good. He had it in the syringe properly. I was impressed because it's powder. You have to mix the liquid and the powder. I was really impressed. And he gave it slowly to the child. When it was done, the kid put his finger on where it was. He pulled it out, put a Band-Aid on. And my new nurse looked at me and said, wow. I said, no, that is a real wow. And I went up to the father. I said, I'm pretty OCD about the way I do things. I said, you are amazing. And I told the kid, I said, so why did you pick that vein? He goes, well, we used this one over here the other time. So I knew this one would be a good time. I said, you are a great kid. It was just such a pleasant thing to watch because usually it's mothers and it was a father. And I was so impressed by it. Now, why did we give that hemophilia that? Well, the kid had fallen at home. We had done everything to stop the bleeding. We rest, we ice, we contain, we elevate. That rice thing that we've heard about, that's what we do for hemophilia. Well, if it doesn't work, then they have to go on and do the other treatment. Now, there are some very mild type of cases of hemophilia, and sometimes that little desmopressin spray that we can give. and that can stop it. Sometimes there's some aminocaproic acid that we also use, but usually it's the desmopressin, or we give that the whatever the clotting factor that's missing. As I said with hemophilia, number one, there are many kids that are young, that are toddlers, that all of a sudden we find out they're hemophiliacs. Make sure we protect that house. You know, coffee tables, sharp edges, make sure they're padded or get a new one. Protect, protect, protect. Very big concept. Safety, okay? Now their teeth, remember, hard toothbrushes are going to create bleeding. So soft toothbrushes, okay? If they fall, make sure that they stop, they elevate, whatever, knee, elbow, hand, whatever. Make sure it's elevated and that they put a ice wrap on it, and then watch it. If it doesn't stop, then they need to call the physician and maybe give that home infusion. Like that boy who came into the ER, he really didn't need to, but it was only the father who didn't know, should I or should I not? And I just want to be safe. What happens with hemophilia, especially if it goes into the joints? Well, it causes that hemarthrosis, right? That swelling in the joint. What does blood do to that joint sac? It corrodes it, and it makes it not workable anymore, and they become crippled. So we need to protect this child's joint to keep him out of a wheelchair. That's the whole big thing. So hemophiliacs can live a pretty normal life. They just have to know their therapies, what to do, and follow good with it. There is some gene now that we're working that can probably help cure it. Not completely done yet, but almost there. Now, immune thrombocytopenia purpura, ITP. What did I tell you what P was? Platelets, right? Decrease in platelets. It's like having one of the factors missing. Platelets you need for bleeding to stop. So what do we see with ITP? And that's what I'm going to call it from now on, ITP, platelets. We're going to see, of course, you do a CBC, you're going to see a very low platelet count. It could be 10 or 20,000, and it should be a minimum of 100,000, okay? So you're going to see these little purple type of little rashes. I have seen many of a child come in with ITP, and they come in because the parents have noted some bruising on the child. They've noticed some like those little purple rashes, and the kid doesn't go outside and play. So I don't know where he got bruised from, type thing. Another thing they come in with, nosebleeds, excessive nosebleeds. And then they go and do a simple CBC, and guess what they find? Low platelets. Many times you do see it after an upper respiratory infection, viral. It's a viral infection, okay? So how do we treat this once we figure it out? Well, this can be cured. Something that doesn't have to stay there, but it can become a chronic condition. So we're going to about almost a year of treatment to take care of it, but we're going to give the IVIG, the immune globulins. It could be once a week, once a month, depends again on physicians. And we also give anti-D. Now, if you have a child that's admitted to your unit and you know they have a history of ITP, which means they bleed easy, right? What things are we going to be worried about? Well, we're not going to do any IV pinches, IM injections, sub-Q injections, unless they absolutely need it, because guess what? They're going to bleed and bruise. So we have to be very careful on how many pinches. We're going to be watching them, their teeth for bleeding, stool, urine. Are they bleeding from anywhere? If we are in the hospital, most likely we're going to be doing, daily CBCs to look. Many of these children, they'll put in a central line, so they only have one stick, right? And we don't have to keep sticking them. And we could pull blood off of that and look at it. Monitor that CBC, and we'll be looking at the platelet counts. Has it gone up? Has it not? And then sometimes with all of this, the IVIG, anti-D, just being careful with them, we might give corticosteroids. That can be part of the treatment. Now, epistaxis, nosebleeds, as I said, this sometimes tell us something's going on with a bleeding coagulopathy that we never knew before. Well, number one, you need to know how to treat a nosebleed. I believe it's one of your NCLEX questions that could pop up that you could have. So what you do is, number one, what happens when a kid starts bleeding everywhere? They start screaming and yelling and running around. Oh my God, I'm bleeding to death, right? The heart rate is beating, 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 and guess what happens? They bleed, 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 bleed. So number one, get the child calm. Have them sit on the mother's lap, have them facing forward so they blood out of their mouth. You don't want them swallowing it because they'll vomit a lot, because it could be a lot of blood. And you take your finger and your thumb and you pinch the nose and put them forward and do not move for 10 minutes. If it continues to go after 10 minutes, they are told to get medical treatment. They might have to put things that we call like tampons. There are blood, they look like little tampons that go in there and swell up, and they put pressure like around the nose and stop it. Sometimes they have to go to the OR and get it cauterized. So there's many treatments that could be done, but the big thing, how to treat it, and that it does show us sometimes what's going on, with a bleeding coagulopathy. It could be that ITP thing that they just had an upper respiratory that we had no clue about. So very important. Multiple nosebleeds, you need to check it out. Now let's go to something into immune. Now, HIV/AIDS, we know a lot more about it than we did back in the 80s when it first came out. And we know that we're still going to have babies born with HIV or AIDS or not, depending. So what they come up with is that there is a heart therapy, which is a highly active antiretroviral therapy that we start administering to the mother at 22 weeks of gestation. And when the baby's born, we continue it, so that we're trying to stop that virus from going to the child, okay? Now, let me tell you something I think is amazing. So the mother has this child. I've seen a case where a mother with HIV had triplets, 3 little girls. One had AIDS, one had HIV, and one had absolutely nothing. So it doesn't matter. They all came out of the same place, right? So sometimes some kids get it, some don't. Another thing, they can be born with HIV, but through giving these children early recognition that there could be an issue, starting those antiviral medications on them, even if they didn't know before birth, I've seen them convert to no HIV at 1 year old. So just because they're born with it doesn't mean they're going to be with it if they're going to get the proper treatment, okay? So it's not always a death sentence. That isn't a death sentence, but something they have to deal with really closely for their life, okay? So what is our goal for this child born from this HIV mother? Well, number one, our goal is to improve that child's immune function, which is giving those antivirals, right? Acyclovir, big one, right? One of the most common opportunistic infections is what we call PCP pneumonia. So any respiratory distress going on, we can assume it's PCP pneumonia. And we usually see that about 3 to 6 months of age. So we need to be, telling the parents they start seeing respiratory distress, get them in quickly so we can put them on that routine of antiviral, stronger IV type. How do we prevent HIV? Well, we know it's education, especially when we talk about adolescents. That's our high risk group, making sure, abstinence is what we should promote, but adolescents are going to do what they want. So at least talk to them about condoms and the risk of HIV and washing their hands and, all the things that we can do that can help. The one thing that we do must maintain, you have a kid with HIV in a nursery, and it could be an open nursery with 8 or 10 babies in it. There's no other parent's reason for them to know that that kid had HIV. You must maintain that confidentiality because we're supposed to wear gloves with all our babies, right? Because we're trying to prevent infection from going around. So what do we do for the management of hematological and immunological disorders? Well, number one is blood transfusions. You've heard me mention many a times. Be aware of what your protocol is at your hospital. At your hospital, it could be, for instance, do vital signs when you start with a temperature. Hang it up. Of course, it's 2 nurses must sign it and make sure it's the right blood going up. 15 minutes later, take another set of vitals, and then every hour thereafter. What do we see if we see all of a sudden a fever spike, a rash spike? You're seeing an allergic reaction. What's the first thing you're going to do? Anybody? You're seeing an allergic reaction to blood transfusion, and it's running into that child.
You're going to stop
it.
Absolutely stop it. Don't question it. Don't say, maybe it isn't. Well, I'd rather you turn it off than say, let me get somebody else to check, because you want minimal stuff to go in there. Very good. And we know now it's always under an infusion pump and it's run at a certain amount of time. And again, follow your policies. I mentioned apheresis. I mentioned it with thalassemia. With the iron, it does take certain stuff out there. You also can take platelets out and give them to donors. It's another component of the blood that they can take out. A lot of times with these conditions, we'll be doing bone marrow aspirations. It could be xiphoid process and it could be in the hip. Now, it hurts, and it's something you need to let these children know. They do give them sedation. They do numb it on top and put the needle down and numb it within where they're going. But they can actually feel it like punch, and they can hear that, okay? So these are things these children, you're not gonna go and let them know that, but just say, we will do everything to make it as little pain as possible. The parents cannot be there for this one. This is something the nurse will be holding this child's hand for because it is a sterile procedure. So if both parents have sickle cell, what's the chance that this child is going to have sickle cell?
A.
Yes, it is, 25%. All right, let's go into some neoplastic disorders. So half of all childhood cancers are in the blood. So leukemias and lymphomas, that is your blood and your blood forming organs. Leukemia is something that can happen in children, most common form of childhood cancer, more common in boys than girls, and you'll see them ages 2 to 5. Our survivability today is so great, it's so wonderful, but it's a long care in order for them to get there. Now, leukemia is described as an unrestricted proliferation of immature white blood cells in the blood forming tissues, which means your white blood cells are immature. They're not working. They're non-existent, basically. These children, there's 2 sorts of leukemia that you're going to hear about. You have lymphocytic and myelolytic leukemia, ALL and AML. The easiest to treat is ALL. AML takes a little bit more time and attention, but it also can be cured. So how do we evaluate these children? Well, I had a next door neighbor who went into the ER. She was actually older. She wasn't one of the young kids. She was, I believe, 12. She had some bruising on her leg, really bad pain in her knee. She was just run down and she just had no energy and she wasn't herself. And the parents brought her into the ER and it hurt her knee. And she felt, ugh. So the parents brought her in and they did a CBC, right? First thing we look at, bleeding, bruising. So they did that. And they found the immature leukocytes in the blood smear. They found a white blood count of 0.1. It should be what, 5 to 7, some there or higher, white blood cell, which means this is why, and she also had this fever too, like flu-like stuff going on. So with all of those symptoms, what happened to her? Now, today, she's gone through, she's in remission. She got her PhD in psychology from the University of Miami. She's brilliant. So it didn't affect her in the long run, but it was 2 years of her life of treatment. So the first thing we do is do a lumbar puncture because we want to see, is it in there? Is it in the central nervous system yet? Or is it just in the blood systems? We're going to be doing that bone marrow aspiration because we want to see what's happening of those blood cells being made. Are they normal or are they not? And of course, they're not. And again, please tell them it's going to hurt. Now, once we figure all that out, and yes, we've determined it's the ALL, we're going to be starting chemotherapy. Now, the thing about chemotherapy is initially it is intense. Let's kill every germ we have in there, every cancer cell. It is 2, 3 different chemotherapies, and it's 4 to 6 weeks called the induction therapy. This is a goal to get rid of almost all of the cells. So our goal is to achieve remission. We don't want any more cells left. We will put a little bit into the central nervous system just to keep it clear. And then from there on, what we're going to do is do chemotherapy just to make sure we got all the cells, and then we put them on a maintenance. So that first 4 to 6 weeks, you want them almost to be in remission. These kids do have a lot of side effects from that. Now, sometimes we can do a hematopoietic stem cell transplantation on these children, and it does help the body make it white cells that they should, right? You don't have to be a match like blood. It's not like you're A positive and the donor has to be A positive. No, it has nothing to do with that. It could be a relative or non-relative, but there's 2 sorts of stem cell transplants, and you need to know the name. Autologous. Autologous is automatically mine, okay? Auto means it's automatic. I'm going to try mine first, okay? This can be that umbilical blood cord that you save. I mean, yes, it's expensive, but many parents decide to keep that umbilical cord blood. And in this case, with leukemia, they have their own cells. Now, sometimes it doesn't, you don't have it, and now you've got to go on to allogenic, everybody else, all the others. And that's how I remember the difference. Automatically mine is the best, but all the others can work too, allogenic, okay? It can cause, remember, this is somebody else's type of organ tissue placed into you. You can have graft versus host. Okay, just like any other of them. And of course, that can also cause your severe organ damage, just like any other type of transplant. So again, these kids are going to go through a lot. They do put imports in these children. Many of them come into the ER, they have a fever or something's wrong. They've already put their Emla cream on there, which is a numbing cream, and they put a Band-Aid on top. And when they come in and we put the little needle in to access it, it's easy for them because it's numb. They don't feel it. Our goal is to make sure they're not in pain too. Remember that girl, my next door neighbor, she had pain in her knee, and they did make sure she had enough pain medicine to help her. So remember, you have no white blood cells. You also are going to be really anemic. What does chemotherapy do, right? It gets rid of your blood cells also. It doesn't know good and bad, so some of your good cells will die too. So you can have hemorrhage and also anemia. So you'll be getting blood transfusions and replacing, because we know it's from the chemo. We need to make sure that we replace it. And with any chemotherapy agent, you have to use precautions. You know, I've heard some nurses tell me they want to work in pediatric oncology. It's great. Get certified in chemo. These nurses, there are always things out, $25,000 sign-on bonuses. It is a great field to get in, but you're working with children who, many of them can die. So it's really stressful. But I'm telling you, it could be the most rewarding because it's not that a child lives or died on your watch. What did you give that child while they were alive? And when they have a good memory, that makes it, I mean, nothing will make it all better, but it helps. So, prognosis of leukemia. What was your white cell when you started? Was it 0.01 or was it 0.1? I mean, you can make a difference with that. How old were they? Was it the ALL or AML? Male and female make a difference. And then, of course, your blood type, because these children will be getting platelets and they'll be getting bloods because chemo kills that too. So your karyotype makes a difference. So children with cancer. Cancer is something that we treat in many different ways. We can do combinations or just one type. I mean, leukemia is just all chemotherapy. Sometimes we have masses and tumors, so it's surgery, chemo, radiation to shrink it and then to remove it by surgery. As I said, all different things that we use. So one of the things we need to know is when we're looking at cancer, the quicker that they're diagnosed, the better that they will do. And here's some of your signs and symptoms that you might see. Again, that pain, the fever, the ecchymosis, the petechiae, which is what that girl, that was my neighbor, was seeing. And they did get in there. That lethargy, that just feeling bad, and vision changes too can be part of it. Now, one of the things as nurses, we're going to have groups of patients if we work, let's say, on a pediatric floor, and even on an adult floor. One of the things that we need to monitor, especially with immunosuppressed or children with cancers, adults with cancers, is they're not going to have a great immune system. Neutrophils help kill or get rid of infection, right? So if you have a group of patients and one of them has a neutrophil count less than 500, that is the one you're going to visit first. That is your first assessment because that child is at risk for sepsis and they go into septic shock quickly. There's nothing protecting their body. 500 is nothing, okay? Should be 2,400, all right? So be very careful with that. So we get a child who's less than 500, we are immediately going to collect all sorts of, cultures, blood and mucus and urine, etc. But we're going to get those antibiotics in really quick because we don't want them to get an infection because they'll go into the shock. Children can have hemorrhage. All those blood coagulopathy things, their platelets are going to be low, giving those platelet infections and those transfusions, and making sure that these children know that when they're under treatment, that they need to protect themselves, whether you protecting them in their house, or you making sure they're not out riding a bike. I mean, swimming, let them swim, right? As long as they're not trying to jump off the diving boards and stuff to hurt themselves. And we know anemia is part of it. They're going to have to rest, okay? Look at their tolerance for physical activity. Using antiemetics before they vomit. Years ago, they wouldn't let me give medicines for nausea until after they vomited. Isn't that ridiculous? Well, today they don't do that. They say, kid, before you're doing something that's going to cause nausea, give it. They're also using cannabinoids in children, CBD oils, that have worked very well. Again, some parents, go and get it and sneak it. My suggestion is work with the medical professional, so they know what you're doing to help, because maybe it's going to help another child what you did, right? And of course, nutrition. These children are not going to want to eat. They get a lot of ulcers in their mouth. Okay. And because of that, we need to monitor nutrition. Now, how's the number one way we monitor nutrition? Height and weight, right? They're not gaining, they're not getting taller, something's going on. And we're going to be monitoring all the protein stuff in their body, their prealbumin, transferrin, and albumin. Is it okay? These children need high protein, high calorie, and high fat. They need all the nutrition in the smallest bite they can get because they're really going to be nauseous. They're not going to want this. The mucosal irritation goes from mouth to anus, all of that and in between. So making sure that the food is better, not spicy, won't hurt them. Again, making sure they have those antiemetics. And these children sometimes, hurt. So making sure they have something for pain. They don't recommend lidocaine mouthwashes because what happens? It swallows it and they could choke because now everything is numb. So they don't do it routinely at all for these children. Another thing is they're not eating well. So they're not going to have stools the way that they should. So make sure we monitor them and we give stool softeners. So if they're pushing down with low platelets and low bleeding, numbers, factors, you could cause a stroke, right? Pushing down could cause really bad problems. So making sure that they're stooling well. Keeping them active, physical therapy, passive or active, it doesn't matter. And a lot of children get jaw pain. Again, giving them something to help that. They can have blood in their urine. And then we always think chemotherapy, they're going to lose their hair. I've seen so many things, so many fathers, brothers that'll shave their heads to be with them. I used to bring in ribbons for the kids. And I would put a ribbon in my hair and I'd have a ribbon in their hair, or I have a multi-ribbon in their hair, and we send them home for her sister. It's just something that took their mind off of no hair. We made it into, you're really cute today, right? Look at that ribbon. And they do get a lot of steroids. And Cushing's syndrome, even in little babies, right? They will puff up like, I call him the marshmallow man, right? Just puff up really good with it. So making sure they're comfortable, especially the older kids, make sure that their gowns, that you get a bigger size. They don't want it tight on them. You know how you pull when your shirt's too tight? Well, if a gown's too tight, they're just going to feel self-conscious. Adolescence, body image, you don't want that to happen. Again, getting them prepared for procedures. As I said, it's usually sedated, using those local anesthetics, and make sure we do the deeper as we go in, and it does help. Making sure that they get stuff for pain, because pain is really important that we do monitor. And remember, pain isn't just medicines. It could be diversional activities. It could be positioning, could be hot, could be cold. It could be so many things. And making sure it's have to be just narcotics, acetaminophen or Motrin, if they can have it, are all good things that they can use and to combine it up together. Now, lymphomas is a type of cancer in the lymph nodes. Now, there's Hodgkin's and there's non-Hodgkin's, and there is a difference. Yes, we have them older for Hodgkin's and a little bit younger for non-Hodgkin's. Now, Hodgkin's disease involves the lymph nodes, and Hodgkin's disease is from shoulders up. These things will be big lymph nodes sticking out under their neck, behind their ears, cervical, supraclavicular. You'll see something. Hodgkin's, non-Hodgkin's, you don't see anything. So know that difference. Hodgkin's, you can see these non-painful big lymph nodes, okay? Along with these non-painful or painless enlarged lymph nodes, there'll be a cough because they're squeezing against the trachea, right? And they're going to be anorexic, they don't feel good, and they'll have that fever that goes along with it. How do we diagnose this? Well, we're going to be doing that history, seeing how they're feeling, CBC, I'm going to look at, your white blood cells, infections, or something happening there. Your inflammatory factors of your CRP and SED rate. CRP is your C-reactive protein, and then urine, etc. How we get the final diagnosis of Hodgkin's lymphoma is they do a biopsy, and that biopsy will show the presence of Sternberg-Reed cells, and that is Hodgkin's. How do we get rid of it? Well, let's shrink up those lymph nodes with radiation chemo, and then if we need to, we can go in and remove them, okay? But usually radiation chemo, it'll be gone. Again, make sure if it's radiation and they've got these little marks, let's say it's on the neck, those purple marks, because usually they're purple, do not wash them off. They need that to direct that radiation to where it needs to go, okay? One of the things with Hodgkin's that you're going to see is a high risk for fertility. Infertility. It kills, the sex cells. So many of these children will not be able to have children. Now, non-Hodgkin's is diffuse, it's everywhere. You're not going to see it. You're going to have all the same sort of symptoms, but you're not going to see anything bulging. It's going to be diffuse, okay? So we're going to be doing a biopsy for confirmation on that, and it's usually through a bone marrow. And then we'll be looking at the cells. This one again is just like the other with radiation, chemo, and again, going through the stages of chemo, induction, consolidation, maintenance, and then of course, intrathecal, going to the central nervous system. But again, we're going to be treating them for all those side effects of chemo. Brain tumors. There's big solid tumor in the brain. It could be benign or it could be malignant. What we'll see with brain tumors is the kid will have headaches, will be nauseous, but it's going to get worse as time goes on. So it'll be nauseous, and then it will continue to start with more vomiting and even headaches that wake them up at night, like really severe. How do we treat brain tumors? Well, we want to try to get that tumor shrunk to get it out, because we don't want to touch any other piece of the brain. We have to, because every part of the brain does something, right? Whether it's speech, whether it is, memory, we don't want to touch that. So just to get the tumor out is all we want to do. Sometimes we do chemo, but usually it's chemo radiation. Postoperatively, you got to be careful with a brain tumor. They've removed something in the head and there's a hole left there, right? So we got to make sure that the positioning is the way the doctor wants. Do we put them on the side of the tumor when we turn them, or on the other side? How far up of a bed can we be? 30 degrees, 45 degrees. All of these things are huge. And another thing is fluid restriction. You don't want too much fluid because you're going to overload the brain. We don't want that. These children need to be taught what's going on before surgery, and the family needs to know what to expect. Sometimes they come out with these brain drains sticking out of their heads, and that can be the scariest thing for a parent. So making sure that they know what to expect, and we want them to try to be what they were pre-surgery. Now, neuroblastoma is very uncommon. Let's just put it that way, very uncommon. It starts with a big mass in the belly that grows across the midline. So it starts on the left side and grows over to the right side. It gets big. But by the time it does that, it's already metastasized to the brain. Usually, you don't see it in the belly as severe as this child of this picture, but they'll start all of a sudden having neurological things. Or you might see swelling around the eyes, or the eyes being pushed out because the brain tumor is coming out there, okay? You're going to see one, if you go in and start looking, you're going to see it's in the belly already. These children, really a rough outcome because it's already metastasized. Again, we'll try surgeries, chemo, radiation, but again, that's all up to the parents and it's all up to the surgeon and physician taking care of them, okay? Now, osteosarcoma. Osteosarcoma is a tumor of a bone, usually a long bone. I've seen it mostly in femurs, adolescents in the femurs, okay? It is something where they'll have pain in the leg. Sometimes it's down the tumor closer to the knee, and they'll have pain in the knee and swelling. I saw a documentary on a football player who had it in the knee, and he was a really good football player. And he couldn't play, the last final winning championship of his senior year or something, but the game was dedicated to him, one of those things, because he had osteosarcoma of that bone there. Now, that whole bone needs to come out. The whole femur bone has to come out. So can you imagine you're left with a hip joint with a socket in there? What do we do? Well, there's two sorts of surgeries, but we want to salvage that limb at all possible, which means what? They take the lower extremity and put it up into that hip joint. So now you have a short lower extremity coming out of the hip. They can do it. They can salvage it like that. Now, what does that mean for the child? There's a place to put the prosthesis and they can step on it, right? Before they didn't have anything. It's just the prosthesis trying to fit somewhere where the hip is, and there's no attachment. There's nothing sticking out there. So it's very hard to put it on there. So we do like to do that salvage of the limb. They do chemo, they do sometimes radiation before to shrink it. They try that. Now, Wilms tumor. Wilms tumor is a tumor of usually little boys. It's usually 3 to 5, African American. And I saw only one in my whole career. And the kid came from Haiti after the Haitian earthquake. We had gone over there, our hospital, and we found him. And they got to us by a religious group, and we took care of him. And the religious group that brought him in didn't know anything about the kid. They just said, we were told to pick him up, bring him here, and here is his records. They were all in French, so I couldn't read. So now what do? I got a kid from Haiti. I don't know what to do, where to place them in the ER, and I had to do a thorough assessment. So I got on the kid's level and made him feel comfortable, gave him stickers. And remember, I don't speak his language, so it was a little bit hard. But then I was able to do vital signs, listen to his chest. I went listened to his abdomen. As I was listening, that left lower quadrant had like a softball sized mass in it. And for some reason, and I don't know why, I knew it was a Wilms tumor. Fit into that mold, right? So what is the big thing about Wilms tumor? Wilms tumor are extremely fragile and they're cancerous, and just touching them can cause micro little pieces to come off, and it could cause metastasis. So the big thing with Wilms is do not touch that abdomen. Leave it alone. So immediately I knew. I went in, told the charge nurse and the doc, and we put a note on the chart, leave the belly alone. And we went in, we did, a CAT scan, and we saw it. The kid was admitted. They did radiation, they did some chemo, and they went in and they took it out. Now, taking it out, it's on the kidney in the back. So it's something that they manipulated a lot of stuff getting there. So we have to be careful post-operatively with their urine, it's the kidney, and we have to watch out for the bowel because of manipulation. And of course, making sure they're peeing, they're urinating, and of course, watch out for infection. That little boy did well, and he went back to Haiti. And I know that the nursing unit where he stayed got a note from him. Somebody wrote a note in English and send it to us. So the kid did well. He's thriving today. Rhabdosarcoma comes from different places: eyes, ears, nose, in the mouth. These are tumors that come out, and they're very subtle. And if we remove them, they're very hard to see. Retinoblastoma is in the retina. It These are children that you put a flashlight and you see that white glow. Have you ever opened your back door at night? You have a light on and there's a cat or dog in the backyard and you see those glowy white eyes? Well, this is what you see with these children. So these children, retinoblastoma, they've got to go in again, radiation. Don't take that little blue, purple thing off there. They're going to do chemo, and these children, they're going to go in many times. They have to remove the eye. These are children that will end up with a prosthesis, so that it looks like the other eye. You know, growing up in high school, I had a boy in my class who had, I guess he had a retinoblastoma. He used to take his eye out and roll it around on his desk, put it in his mouth and stick it back in his eye just to gross us all out. And I never knew what it was until I was, in nursing. I'm like, okay, I guess that's what that child was. I guess he did good because he was, an adolescent, and doing well for it. Remember, these children need good support, and these parents need lots of hugs, because they're going to end up getting an eye out, and that is very radical. Germ cell tumors. These we talk about. These are your testicles. Women do breast exams. Men should do testicular exams monthly. I had an 18-year-old boy come into the ER. His testicle complaining testicular pain. So when we went to examine it, it was the size of a grapefruit already. It was huge. And when we went in and we just did an x-ray, his chest, his abdomen, and of course we ultrasound it. He already metastasized everywhere by the time he came in. And that 18-year-old boy was dead in 3 months. That's how quickly testicular cancer can spread through the body. So I'll never forget that boy. It was huge. And I follow these children if I can. Liver tumors, the liver's great. They reproduce, right? But again, it's big surgery. They do chemo to shrink it and then they take it out. So today, there is a great survival rate. I mean, even more, I think, than this slide says. There's so many advances going on. There's difference in radiations and chemotherapies. And, it's something that, you don't want to have cancer, but the outcomes are so much better than they ever were before. So these signs that you see on your social media pages, cancer-free, it rings very near and dear to me because this girl has gone through so much to get to be cancer-free, but it's not only the girl. Remember, those parents have been there too, right? So a lot of information today. I mean, I really don't have time to do the Kahoots for you. So I guess what I'm going to do again is I'm going to do the Kahoots for the other class, and then I'm going to share the recordings again. Is that okay with you all? And I will be sending you the Kahoots today so that you have it. Please do the Kahoots and look at it. Those questions are very, very important. Really shows you the concepts, things you're going to see, whether on exams, whether on quizzes, or whether on your HESI or NCLEX. So I really take time looking for them. I make up all those questions. These are not from a book. These are from me. So, and I go over them at least every 6 months, redoing. So anybody who needs any help for the exam in any aspect is more than welcome to join me. I know this quiz, a lot of you went about. It is a more difficult quiz. I think cardiac respiratory is hard. If you want to meet me Thursday after the review, you want to stay on, I can do it then and go over with you all. I can't do it yet because we still have classes doing the quiz, okay? It wouldn't be fair. Anybody have any comments? Okay, I'll see you next week for the exam, or I'll see you in the review, and I'll be sending all your information. Thank you, guys.
Thank you.
My
you.
pleasure.
Thank you.